From Redux and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech.
Thank you, and good morning, good afternoon, or good evening, wherever you are when you're listening to this. I am Jeff Englander. I am the founder and principal of Healthcare Strategy Bullpen, and it is my pleasure to welcome our co-host, Torrin Slater from Redux. Welcome, Torrin.
Thank you, Jeff. Great to be here.
So, real pleasure today to welcome our guest, Joe Warbington. Joe is the industry principal for healthcare and life sciences at Snowflake. He focuses on solutions and strategies for healthcare providers and health systems. He's worked in health technologies and data for over 18 years. You hide it well, Joe. You look great.
It's great.
And he started at Epic and then was at Click Healthcare and VizLib and Astrato before that. And Joe is very passionate, as you'll hear, about population health and reducing clinician burnout. So welcome, Joe.
Thanks for having me, guys.
So, Joe, one of the things we started doing since the podcast is called Discussion with Friends is asking our guests, what was your motivation? What was the catalyst that got you into healthcare?
It's kind of a roundabout story, but maybe some of it is above me. I'm a space nerd. Worked for NASA just a little bit, and this was at the time where I was deciding what I want to do with my life right out of university. So NASA said, we're going to send you to Antarctica to work on some robots and for a number of years. And you're only going to live with scientists, get to see your family a couple times a year. And I thought that didn't sound that great coming right out of college. Let's go somewhere fun. So I started interviewing at other groups, and I met this interesting company, kind of kooky, out of Madison, Wisconsin. And they said, we do healthcare software. Do you know anything about healthcare? Absolutely not, other than, you're a patient. So they won me over with their culture, and I got to tour the town. I was at Michigan State University. I had never been to Wisconsin before. We only get up to Chicago. So I kind of jumped in not knowing what I was getting into and quickly fell in love with what's possible with all of the data, all the things that you could do to really transform healthcare. And so that it ignited a passion in me that I still have for space, but if I can find a way to connect those two, that would be great. So,
we said in the intro, you're passionate about population health and reducing clinician burnout. How'd that come about?
So at Epic, I was on the data team, the now known as the Cogito team. It was Clarity. We were just storing all the data that all the doctors, nurses, operation folks, and we're helping to optimize it. When we're sitting on this treasure trove of information, but it was underutilized, I would say. And so as we started doing more and more work, we started developing, programs and software around chronic disease management, which I think is where I really started to lean in and say, okay, you know what? In my family, my dad, for instance, has diabetes, has had it for many years. What does his doctor truly know about them when he walks into his doctor office? And, they might have some history. And we started to through that course, he was on paper, and I remember that, and his file was just getting huge. So to go to a digital health record was massive, but he saw so many different doctors. They asked the same questions over and over, even if they were on a digital system. And that, 18, 19 years later now, was just up in Michigan visiting them. And it really hasn't changed that much. There's all these systems in place, but it's still so very disconnected. And that's what keeps me going is, I know that this stuff is out there, that we have the technology. It's just applying it the right way.
Yeah. And one of the things we talked about as we were preparing for this was everybody's talking about moving to the cloud in stages. And then, you refer to it as blending. And it's not always kind of the big lift and shift that a lot of people think of. Can you talk about what blending is and the idea that maybe not everything has to be in one place at one point, or at least, initially at that point in time?
Yeah. And this is the world of interoperability, right? There's so many different formats and data points and different players that are at you, as a patient. The just alone the doctors that you see, let alone do they really understand you. And I used to say a while back, like Target knows me more as a patient, as an individual, more about my health, my wife's health, than my doctor does. Like they knew we were pregnant with our second kid, I think before our family knew, just based on building that profile that our doctors know, not until we really went in. But that the data lives in so many different places. It's really not just you own your healthcare data. Really, it's really should be the thing. But what gets entered into the EHR is just one small slice of your overall health factors. And so that was like illuminating when I learned that, working with some customers and up at Jefferson, Thomas Jefferson University in Philly. They had a population health program that I went through. And that was, 20% of your data around your care lives within, if you're lucky, a digital EHR. And you see, you have regular visits and telehealth and things like that. 80% is outside. It's the social determinants of health. It's connected in another spot. And so when I talk about blended, it's to truly understand us as an individual, as a human. It's not just all that, sick care data that's put into the EHR. It's still really important. And even with 20%, there's so much mining and research that can be done there safely and responsibly. But when you add in that element of other things from the community, you're sending a patient home, but they don't have a car. Does your doctor know that? They might right then and go, oh, we have to order a cab. They can know that ahead of time. Or they're prescribing these things, but that patient can't afford to pay their bills and get, air conditioning, or they have a HEPA, vacuum. These types of things that just keep them coming back because we didn't fix underlying root causes. But, you shouldn't burden the doctors with all that stuff either. So it's like all this data lives everywhere. If we can blend some of that, there's definitely interested parties, particularly the IDNs, the payers plus the providers, those payviders, we call them, right?
Right.
That they're taking, I think, a better approach at this and a look at it at a different perspective, that we need to prescribe perhaps these other things that aren't just medications and procedures.
That's a really good overview, Joe. Well, Torin, let me bring you in here, and I apologize I neglected to introduce you a little more fully and give your position. So if you wouldn't mind doing that for our guests, and then go ahead and fire away at Joe.
Awesome. Thanks, Jeff. Yeah, so as I mentioned earlier, my name is Torin. I've been in healthcare for the last 11 years. Didn't start my career in Madison, but have been both on the management consulting side as well as on the operating side, and currently launch new partnerships at Redox, one of those being Snowflake, which is why I'm on with Joe and Jeff today. So I think, Joe, you have a really interesting background, right? Having worked at Epic as well as a handful of other digital health applications, and now at Snowflake. And you started going into this a little bit just from kind of where the data sits, right? There's the EHR data, there's other cloud platforms, there's other data that may sit across other providers. For those that may not have the level of appreciation that you have, kind of contrasting the role of the EHR and the role of a platform like Snowflake, I'd love to hear your perspective, maybe by providing some examples, like what are EHRs really good at, and ideally how should they be deployed and used? And then what are large platforms like Snowflake really good at, and how does that kind of compare to the role of the EHR within healthcare?
Yeah,
that's a great question.
There's a lot there, of course, but I would say we try to play nice with everybody. So you're going to have dozens of systems at a healthcare organization, and the EHR, in most cases, is the primary system that everybody has to get behind. It's how you take care of your patients. That's always number one. So when the EHR is involved, that is knocking down typically all the clinical, the revenue cycle related use cases, these things. They do that really well because it's where the work gets done. It's the workflow, application. It's where all the information gets entered in, whether it's right or wrong, whether the registrar typed in the right, zip code for the patient, or they're coming through. And there's so many different entry points of data in the health system. And the EHR is one of those first lines and contributes a tremendous amount of information. But it is just one of them. So when organizations are picking Snowflake as a platform for their data strategy, it is obviously encompassing everything from the EHR as much as possible. But there's so many other things that happen outside of there. So one really common is, how do you, your EHR is not your HR workforce system. It typically is not that. The companies are really good at clinical, they're really good at rev cycle. So a lot of organizations have Workday plus Epic. And, Epic doesn't necessarily know Workday that well, and Workday doesn't know Epic. So people come to Snowflake to bridge the gap between those two. And some really important things pop up around there, especially, over the last few years, where there's been a huge illumination of the staffing issues that organizations have. So if we know all the demand side, like all these patients are coming in, they need these procedures, they need these things. But if we don't have the nurses and the doctors to perform those actions, we're still in where I'm at in Tampa. There's a couple hospitals that don't have all of their beds, activated because they don't have enough staff. And so you want to bring together those two worlds of very critical business systems and all the data behind that. That's just one example where you want to blend this information together and understand we have the staff, we have these needs, and Snowflake's a great way to bring together those different sources. And that's just within the ecosystem of a hospital or a health system itself.
Go ahead, Torrin. Did you have another question?
Yeah, no, I think that makes a lot of sense. And I think, there's obviously varying levels of capabilities that the various tools have, whether it's Epic or Cerner on the HR side or Workday on the HR side. Like, what would you say are some of the biggest challenges associated with getting that data into Snowflake, right? Once it's in Snowflake, that's when Snowflake can kind of unlock a lot of its magic, right? But what about getting the data in?
So there are some health tech companies and EHR platforms that are fully powered by Snowflake. So it's the back end to everything. That's that's the ideal state for us as a company, but we know that's not going to be possible across the board. So we have to be able to ingest that information, and it comes in just like the interoperability challenge. So many different formats, different standards, decades often of technical debt and complex data models. And so just bringing that into a platform where you can quickly interrogate it, blend it with other different information sources, and get a grasp on that, that's usually one of the first things. So they are taking what has been predominantly an on-prem system. And Jeff, to your point, like moving into the cloud, 5-6 years ago, maybe 6 years ago, a little bit before that, I was like, good luck with that stuff. Like healthcare is not going to want to do stuff in the cloud. And now it's, why aren't you? It's actually a lot more secure in many ways because an on-prem data source is easy to social engineer and get access to, but it's still out there. So it's pulling information from on-prem, but also from your trading partners, let's say from the payers that have been digitized much earlier than a lot of providers. Life science companies have had deep pockets in technology for many, many years ahead of providers. So it's like your entire ecosystem is saying, we have all this technology, we know it's possible, but still, and I pull this out because I want to show you, I was at Epic this last week with my family. We kind of were walking through amazing campus, and I know it's a little blurry there, a huge auditorium. And then the last thing that we kind of stopped by, I grabbed some water, we're playing around with all the different artwork, is this thing. And I joke about this on your guys' podcast all the time, but fax machines still exist in healthcare. And it's even at Epic because the doctors have to run away, out of training, and they might have to, sign something over a fax and fax it back. And it's like this information is in so many different formats and varieties that, we're going to have this challenge for a long time. But if you can start bringing it together and tapping all these different things, you start having a better handle on, instead of that work of just moving data and copying it all the time that happens, and then nobody actually unlocks it. So that's the blended side. But we have to play nice with all of the different formats and varieties because I don't think it will ever truly live in one spot. And that's where, working with Redox and Snowflake has a way of tapping into those things in different systems so that they can join the party when they're ready, but we're not going to just stop things from working today.
We may need to frame that picture and put it in offices for anybody who's under 30,
I can still hear what it sounds like when it sends a fax. Yeah.
Oh my God. We'll move on from there. So where do you typically start, or where, it's maybe different from, you said 6 years ago, moving to the cloud.
Oh, yeah.
Where do your provider clients and maybe even your payer clients, where do they typically start, or where would you recommend they start as they think about moving to the cloud? And then, what's the best way to think about a plan to do that?
Yeah, the technology has caught up. Data warehouses and data lakes have been out for a while, and healthcare has definitely experimented there. Those projects, in some cases, I was working with sites prior to Snowflake, were like 10-year projects to get the data warehouse ready. And you think about that, like it's going to take 10 years for us to have that one single pane of glass to ask a question. You can't wait that long. You can't even wait a year. So the technology has caught up that it's so vastly easy to get started, to connect to different data sources and bring it in, that we've taken all that work that was really low value of having to, spin up infrastructure and servers and license things and set up all these policies and security and just make it a platform as a service. Much like you maybe a few people today, if you're a photographer, you probably have like a hard drive hooked up to your laptop and store your photos. Others just like, I use Google Photos, or I use what was Flickr and all these different things. They've taken away that, and it's backed up and it's readily available, and it can go to your next computer. Or I had my phone crash recently and I was worried I'd lose everything, but it was all backed up in the cloud. That type of stuff is there, the redundancy, and I don't have to worry about that. So that's what we try to get folks to think about. Where's the value? It's in connecting the different data sources, actually presenting it to the business as quickly and as safely as possible, and not like data warehouse and analytics is off in its own corner or in a basement. It's integrated into our work. Like we wouldn't do these things without all the data we could possibly have at hand, because it's the best thing for the patient. If we don't make them fill out that form, 12 more times, we already know that information. Maybe we verify it, but and that goes to say with all kinds of data, you shouldn't have to go to a new doctor and get x-rays again. They should just transfer all those types of things happen today.
Torin?
Yeah, and I think that makes a lot of sense. You started articulating some use cases, right? Whether it's at the point of registration or further downstream in kind of a patient's care journey. What are, just based on your kind of, where you sit across the healthcare continuum, like what are some of the use cases that you're most excited about that, you think some of these large data platforms like Snowflake combined with something maybe like AI and large language models could unlock?
Yeah, there's obviously like a maturity scale of where folks are. And so our vision and our kind of mantra is if you don't have a data strategy, you can't have an AI strategy. So right. It's foundational to this. And, working with you guys at Redox too, we know and understand the timeliness of that data is really critical too, because if we start putting AI on top of data that was from yesterday or weeks or months ago, what's it going to surface up? How can we actually act on that? So we're pulling in those things. And this is where organizations start with the foundational things. We might, throw them in different streams like financial and clinical and operations, but it's in stitching these things together where people are actually having those challenges in a health system. Like I mentioned with the staffing and the patient care. If you don't have, both those sides are typically very much siloed. If you can bring them together, we can accurately do this stuff. And that's where I'm seeing a lot of the interesting use cases pop up. Because if we truly use AI in the right way, not just chat and ask questions or summarize things, but can it direct me to the next best action based on data that just came over across the, an HIE interface, because that patient was just seen at another facility outside of our health system. That type of stuff is possible today. But normally it just completely goes unnoticed. You don't even know that the patient showed up at an emergency department outside of that health system until 60 days later. The claim lag of things is huge. And that care, that impact that you make to care right there is really challenging. But I'm going to catch them in the last hour. And then they might actually still be there at the facility. So that's like this world of analytics shouldn't be off on its own silo, but also operational stuff. It's great. how do we blend these two worlds so that we know as soon as we start asking questions, this is the most up-to-date information. It's connected into what matters.
Now, you gave the example earlier, Joe, about working with the EMR and then Workday, and that obviously you have to know who's there, who's getting paid, how many people you have. I mean, that would be a great example, I think, where you could provide predictive analytics to see, okay, how can you start staffing up those rooms? Or are there other resources such as virtual nursing and other things you could do maybe to free up more rooms? Are there other examples you can give of, systems that you've worked with and places where you've kind of unlocked that hidden value?
Yeah, there have been some, I think, in this world, like things related to real-time claims and not waiting the 30 to 60 days for it to be fully adjudicated. And one, this was presented not that long ago, so it was a public story. But if you're going to get your teeth cleaned and you have dental insurance,
how did you know that's right after? Literally, swear to God, right after this show.
No, really? Okay. Well, if they're not on, Pacific Dental, which is a care provider, but also insurance, and they work with Delta Dental too, it's possible that you could go in today, get your cleaning, walk across the street to a different dental office. They'll still run your insurance, and you'll get another cleaning, and you can just keep doing this. And there's some fraud, waste, and abuse related use cases there. When you are able to grab it off the line, right there, you can have your second appointment tomorrow. If you try to go back and do that, Jeff, they would say, oh, wait a second, you just had care, down the street.
Yeah.
We're not going to be able to provide that to you. And there's a tremendous amount of cost savings, but also reducing the waste and fraud as well. That type of thing hadn't been possible before because it was just point-to-point stuff. But now we have all the analytics plus this stuff. We can run some really truly operational workflow related things with that data.
And that all drops right to the bottom line too.
Absolutely. Yeah. And so they prove this out. They go, this is one of our, if we could only pick one thing, we do this time and time again. Mm-hmm. And you have to think there's so much of this happening, and it's not a punitive thing, but it's just efficiencies and operations. And you can't really do that anywhere else in any other industry, kind of shop around like that. But healthcare seems to be that just a little bit further behind there. So people will game a system when there's a system to be had. And this can kind of stop those things. So I think about that one quite a bit, what's possible. And the other one is wait times. Like I think many of us in the last couple of years figured out how nice maybe it was to have a telehealth visit and not have to go into the doctor, or even like sit in your car and then they page you with that little, restaurant buzzer. I love that. It's gone now, unfortunately, and you have to go wait in a waiting room. But all that data is tracked. Can you expose it to your patients through a website or an app where, they can see which urgent care should I go to based on wait times, and give some more of that consumer side to the patients? That's all just data flows.
Yeah.
And, putting it in the hands of the right folks so they can make decisions too. I think we're starting to demand that more as patients of our health systems and our providers. And because we experienced it just recently and we know it's possible, or we see it in other categories. And so I always like those things where we know it's possible, we should be doing it, makes everybody feel better. So your Press Ganey scores go up, all that stuff, and everything's interconnected, and you don't have many penalties. And so there's a really nice circle there of, if you use the data in the right way from the right spots, you can unlock a lot of value.
That's great. Torin, let me let you get in here.
Yeah, I think you've brought up some really interesting topics, Joe, and you keep talking about kind of this distinction of like, yes, once the data is in, that's like you've solved, just the beginning of kind of the downstream value that ultimately will be achieved from that data. And there's a bunch of different teams and users that are going to be working on the data, right? You have the data warehousing team, you have the analytics team. How have you seen customers or just folks that in the industry kind of successfully work together across departments on a platform like Snowflake, once the data is in Snowflake, to actually realize a lot of the potential that we're talking about here? Yeah,
that's a good question. And I am, I mean, I'm a technologist, so I can get technical enough, and hadn't worked at Epic. I saw a lot of different things and had to install databases and be a DBA for a little bit. But I had, over the years kind of unlearned a lot of that. And it was kind of afraid to come to Snowflake because can be very code forward. Like there's an interface where you can just ask whatever question in SQL, but you had to know how to write the good SQL. That's all just changed in the last 6 months with, Gen AI. So now those interfaces are there. And I feel like my skills have been up leveled significantly because I know the questions I want to ask of the data. I just might not know the best way to do it. But the Copilot kind of experience that folks have now, just as a pseudo developer, I'm able to ask questions that just weren't possible, let alone if you put that search style interface in front of folks. They don't have to. I spent a lot of my career building reports and dashboards and trying to get the right information in the right visual format and make it interactive. And then it's one of the most, saddening things to see the dashboard that you worked on for, weeks and weeks just not get used at all. And all they wanted was export to Excel because they were comfortable with it. But now AI is leveled that playing field. So they can ask those questions. I could still have my, nice dashboard that's going to be presented in a meeting as well. But they can get to the questions a lot faster now. And so it's kind of unlocking. That's where I really love where the AI is fitting in. It's like this Rosetta Stone. And especially in healthcare, and you guys live in this at Redox, there's so many different code sets and formats and normalization. And I might know my CPT codes really well, but I don't know how to map it into ICD-10. AI can help you with that now. It's the Rosetta Stone of this stuff, let alone a doctor does not know SQL, but they can now ask those questions and get very good results coming back. And that's where I see some really exciting things lighting up. And it's time to value. They're doing this stuff so fast now. It was a project. It was a 6-month project plus an application or a dashboard. And now it is, they're surprising themselves at how fast they're able to answer these things because the data is landing and now they're hungry for more. And that's where, these other use cases are popping up and really unique things of if we just had access to this information faster, we could ask better questions of it and get the results better. So it keeps me up at night, which is fun because I know I'm thinking about this stuff a lot. But it's moving so fast and AI is just accelerating it like crazy.
Yeah. And I think just quickly, Jeff, the data normalization example that you mentioned, that often I think is overlooked, right? The example you provided makes a ton of sense, but also just things so that's a transformation from, CPD to ICD-9 or 10. Even things as simple as, how gender is inputted into the EHR, right? It might be M in some instances, it might be MALE for me as an example in other instances. And I think leveraging tools like AI as well as companies, whether it's IMO, which is a Redox partner, or Verado that does a master patient index to normalize and harmonize a lot of that data before it hits Snowflake or once it's in Snowflake. It's a subtle change, but I think that can unlock a tremendous amount of value to actually make the data usable to then, leverage some of these additional functionality that you mentioned. So I just wanted to make sure that point was explicitly called out because I think it's sometimes overlooked.
That's a very, very good point because if we get this wrong, if the AI suggests something and it's wrong, they'll abandon it and we won't use this incredible technology. So you have to get that. That's where you get going back to your data strategy.
Right.
If there's 5 versions of a patient record floating around your ecosystem because that patient was seen here on this EHR, the claims came over from here, their name is spelled slightly differently, it might not match them. So you need to do this work so that you present the right results. And there's a lot of cases where, and this is pre-AI, but I remember something where a birthday card was sent to a family member, but their child had unfortunately passed away. Mm-hmm. And that was the worst thing ever. They received a birthday card, but the kid was been gone for a while now. The health system didn't know. And they were just operating. I think it's a great thing to do. But that patient had 2 records in the system and nobody knew it. And so that stuff is out there all the time. There's so many silos of the stuff and duplicated, unnormalized data. It's critical because if we get it wrong, there's huge ramifications. And in AI, it'll just like amplify it. You don't want to use this bad data 1,000 times over. It's so easy to do it so quickly. So it's imperative, but it shouldn't be a barrier to this either.
Yeah.
But that's where I find, applying it responsibly is really key. And maybe if the EHR is going to do that really clinical AI stuff, let them do it. But go out and find like Jeff, your thing about predicting, staffing related things, attrition and recruitment. That's great. There's sensitive data there, of course, PII, but there's not a patient life on the line directly. So a lot of folks are trying to apply it in some really unique, creative ways because there's tremendous amount of opportunity all around that while we're figuring out what's the best approach clinically for all this stuff.
Yeah, I think you gave a great example too, Joe, of just kind of the need to really work on data integrity and data completeness. Can you talk about oftentimes when we're dealing with senior leaders at providers, they're a lot more hesitant to spend that 12 or 16 months or even longer really cleaning the data. It's not sexy. It's not it's a lot of work. And oftentimes the board is much more, hey, everybody's getting AI, let's get AI, and like we can do this with AI. But people don't realize that underneath you've got to have really good data, and as you mentioned, it's got to be deep and real time. So what are some of the steps you've taken when you work with people to help them understand this, that you can I think one of the people at Microsoft said that you get a 5-to-1 return on the cleaning and data integrity work, and just how do you help people with that issue?
Yeah, that's it's a good point. That's an interesting stat too, and I imagine that they're proving that time and time again. We take a very big stance that there are core, we call them data products. So it could be tables and different things from many different systems, but a patient 360 core data product means, to Torrin's point, like it's normalized, we've standardized, there's identity management built in, so we know when somebody queries this information that's that patient. So we've eliminated all those, the dirty data side, but also, feedback in. We still have to figure out where did it get entered in the wrong way, or what was that entry point? Is there something wrong with the system that's capturing it? So analytics often helps fix those systems upstream. So we want to illuminate that early on. And it's funny because like AI can be used for that as well. So it can go through and find this stuff much faster than an individual or a team could. So we're like applying it to the data cleansing side of the world as well, and offering up anomaly detection. So when you enter into a contract with a new payer, maybe they format things slightly differently. The AI can figure this stuff out and kind of highlight this so folks can know what's coming instead of figuring it out much too late. So we're trying to apply it in all these different cases. It's, as I said, it's not just that search side, but data normalization across all industries is huge. It is we can't do everything. So we need partners that know this world really well. And in healthcare, that's, experts like you guys and code set experts like IMO that Torrin mentioned that, they're, AI is behind it in little parts, but they've been around. They know how to translate this work and it's verified and certified, those things. So we try to work with that as well. The outcome of that or the output of that could be used then. It's the safer thing to throw at the AI instead of just let it run against all of your data.
Yeah, that makes sense. Well, Joe, let me ask you one last question, because I know you're kind enough to join us right after you get back from vacation with those two lovely young kids who we saw in the pictures.
Yeah.
And one of the things that is always an issue is healthcare is kind of a do no harm mentality. Move slow, be 100% sure. How do you bring that IT mentality that you see in other industries into healthcare, or at least closer to those other industries?
It's, I think we're lucky and fortunate in our industry that everybody knows and experiences healthcare in either directly, you yourself as a patient or a family member. So I find it's really important and easy to have empathy around that. And so, remember when you had to, take your mom in for this thing, how challenging that was. So I try to apply a lot of that of, okay, well, we know it's possible. It wouldn't happen in the financial side. You have that nice, neat app on your phone. Why don't you have that for your doctor? These types of things of like, that it could work this way. So there's a little bit of that. Like if we aren't frustrated, then we don't care about it anymore. So I live, like my colleague Todd, he's like, we live in a state of constant frustration in healthcare and health tech because we know what's possible, and that's the applying it the right way. And it has to be safe. It has to be responsible. And you don't want to be on the front page of the paper or, on Google News because you did something incorrectly with the data that you're protecting, that you have for your patients, that you transmitted somewhere else. So, and when AI does that, it can amplify it and roll stuff out so much faster. You have to be extremely careful. So we're working with groups, and I'm sure Redox is as well, of consortiums and coalitions that will put policies in place and help with, laws that will come out and are coming out around healthcare and use of AI and responsible AI, so that we do this the right way. And to get it wrong is going to be catastrophic. If you get, if this happens in another industry, if Netflix sources up the wrong next show, that sucks. But if it tells you should take this medication and you do, and it's really bad, there's a whole other world of pain there. Yeah. So there's so much more critical things here, but because we all interact with this system at so many different levels, I think, us as patients, we will start demanding more of this. Like, why is your website terrible? I can't even wayfind. I can't get through. I know I need to get to this patient room, but I can't find my dad. Like, just put it on my phone. I just want that type of thing. I know it's impossible because I can walk into Home Depot and they can tell me which aisle and which screw to get. I know we can do this. So it's that type of thing that is really fun. So I know we're doing good work. It just takes a little bit longer.
Now, are you working with like Chai and Train or any others that any others that you can mention, or just so people understand who to look at for some of these standards?
Definitely Chai. That one's come up consistently, and we've joined. Many of our customers actually are part of that, as I think founding members of Chai as well.
Okay.
So they were actually suggesting this as we have provider councils and advisory boards. So this comes up quite a bit, as you imagine. And we go, we need to have a stance on it as a vendor, but also you should not just listen to your vendor on what your AI strategy should be. But we also want to make sure we're in the right groups and bringing together the right folks. And the way we're thinking about it is going to be the way you want to use this technology safely. So we want to participate in those types of things and learn. And then the great part of my role is trying to share those stories where possible. And that's what I love about the provider side, especially, is you're not really competing. Maybe like if the hospital is across the street from another hospital, they're competing for members and patients. But vast majority of the use cases I share, folks will share who they are, what organization. They will happily send over the information, the code, anything behind it, because they know it's for the betterment of everybody. So that's why I really love this. And that's, goes back to like, why did I choose healthcare? It just time and time again showed me like, we're not really competing. We're trying to figure this stuff out all together in many different ways. But when somebody gets it right, everybody gets behind it and they'll share it. And they're not like holding it super close to their chest anymore.
Well, that's terrific. That's been a great overview, Joe. Torrin, did you have any last questions before we let Joe get back to catching up from his week off?
I think last one quickly, Joe. If there's one thing that you were most excited about between now and the end of the year relating to everything we've talked about, what would that be? I don't mean to put you on the spot, but
that's funny.
But he will.
Yeah. My wife would say he doesn't think that far out in advance. I'm like, what am I doing tomorrow or the rest of this week?
Yeah, I'm the same way.
Yeah. So I think it is, what excites me is when folks turn on these interesting use cases and then they share it, present it, and then just give it to somebody else. So we have that happen every so often, and it feeds me with stories. They're feel good stuff. So I'm hoping a few customers will do some things really interesting and outside of just the provider side. And I think that's where like working with you guys would be, to a payer, to a life science company, to a tech company, that we can kind of create a really interesting network of things. So I'm looking forward to something around there where we can just knock down some really big stuff together.
Yeah, that's particularly relevant in healthcare, right? You need that first mover, and then everyone else will follow.
You got it.
Well, thank you very much, Joe. I really appreciate it. Appreciate you coming on, right after you got back from vacation, and all of your time. And this has really been a very helpful overview with a lot of great points, and look forward to following what both you and Redox together are doing around this.
Thanks, Jeff. Thanks, Soren.
Bye-bye.
So with that, we're going to transition to our discussion articles. The first article is healthcare impacts following the Chevron decision from the Brownstein law firm Client Alert. So as many of you may know, on June 28th, the Supreme Court overturned what was called the Chevron doctrine, in part because the original case involved Chevron, the oil company. And that had required courts to defer to federal agencies reasonable interpretations of legislative statutes within an agency's purview. The actual decision came in the case of what's called Loper-Bright Enterprises versus Raimondo. So oftentimes you may hear it referred to as Loper-Bright as well. The rationale behind the Chevron decision was that agencies and their staffs of experts and specialists in their particular field, such as the FDA, HHS, Federal Communications Commission, more so than judges, should receive deference when the courts review these different agency actions. And while the decision specifically stated that the court won't use this decision to overturn previously decided cases that relied on the Chevron doctrine because of a decision in a related case called Corner Post, the statute of limitations was extended such that it began to run when the regulation affected the company, and that subjected a number of regulations to challenges. So, under the Chevron, the net effect would be that under the Chevron doctrine, courts were required to determine whether an agency's interpretation of an ambiguous law was reasonable, and it gave the agencies the ability to advance their priorities within the scope of the authority governed by Congress. And you would often see maybe a little bit of push of one direction or another direction, depending on which party was in power. The overturning of the Chevron doctrine is expected to significantly hinder the ability of regulatory agencies to issue rules without significant legal challenges. And it'll also mean that judges with varying degrees of expertise are not going to make some of these determinations about the scope of the legislation, and that the ruling may lead to a patchwork of different health regulations because lawsuits filed in one federal jurisdiction may result in a contradictory ruling and regulatory requirement with those in another. And it means that healthcare policies for patients could differ from jurisdiction to jurisdiction. And the regulations that are most potentially subject to these issues are ones that are have substantive requirements. And I know this is pretty dense, so bear with me. Substantive requirements that are not clearly authorized by statute, as well as new programs based on broad regulatory authority. A couple in healthcare that may be impacted are CMS's minimum staffing requirements for nursing homes and HHS's non-discrimination regulations, which required such things as language assistance, accessibility, and non-discrimination based on sexual orientation. So, excuse me, a very big issue could lead to a lot of regulatory uncertainty and a slowdown, in what's going on with healthcare regulations. With that, let me take a sip. And Torrin, your thoughts?
Yeah, thanks, Jeff. That was a super in-depth, helpful summary. I think so. I was actually surprised to see the outcome of this. As you know, healthcare is one of the most regulated industries in our country. to think that this kind of new go forward way of thinking is going to limit the power of a lot of these agencies, I think presents both opportunities and a ton of risk as well. I think, as you highlighted, what I'm most concerned about is, any slowdown that this could have on getting things done. Healthcare is already behind. It's slow moving. There's a lot of bureaucracy at play for good reason a lot of times, right? Like we need to protect things like patient privacy. But the biggest risk I see in the near term is, a slowdown in policy decision making. That being said, I think optimistically this does possibly, give some of the larger incumbents like payers and providers an opportunity to have more influence that they may otherwise may have not have had, given some of the power that the agencies had. But a lot of that is going to take time to really determine, ultimately who the big winners are here.
Yeah, and I would agree very much. I mean, I think there are some people who are saying that the Chevron doctrine had been curtailed a lot in recent years. But my concern is, I think, as you say, is first of all, healthcare moves slowly enough as is. Second, it's very difficult to get any kind of healthcare legislation through the Congress. And now if Congress has to be more detailed,
Right.
I think that's going to make it even more difficult if they have to specify very detailed implementation instructions and regulations. And then the other part that I'm a little nervous about is you always will have people who are against regulations that have been passed and promulgated, and now it's almost a free-for-all for what's going to go happen in the courts for the next X number of years.
Yeah.
So I totally agree on that. Any other closing thoughts on this article?
No, I think that last point that you made is an important one, right? I think this obviously gives more power to the states, and given the varied kind of beliefs across different states in the U.S., I think we will see a lot more differences and nuances state by state, which will just be important to keep track of, and could be somewhat detrimental as it relates to healthcare and patient care. But we shall see.
Yeah, I think certainly means that companies have to be, healthcare is already very much up on regulation, but even more so, almost on a jurisdiction by jurisdiction basis, which as we both pointed out, could be a very difficult issue.
Yeah.
Let me move on to the next article, which I'm sure we will come back to again and again in terms of the article's overall tone. This is from VentureBeat. It says Gen AI's impact on healthcare, cutting edge applications and their challenges. And the article makes the point that despite all the opportunities with AI, there are significant concerns, which I think everybody recognizes, around output, accuracy, transparency, integration, data privacy, ethics, bias, compliance, etc. The integration of AI into healthcare, the article makes a point, is not really an evolution, but a revolution that holds tremendous promise, which, we were just talking about with Joe, of accelerating patient care, improving operations. We gave the example of, working with Workday and medical research. So, the article talks about how AI is good at certain time-consuming repetitive tasks, like summarizing clinical appointments, what many people refer to as ambient clinical intelligence, and also streamlining a number of administrative processes like scheduling, billing, patient management. And AI can also improve diagnostics because it can analyze vast amounts of data quickly and accurately, and it can support personalized medicine, because of analysis of genetics, lifestyle, medical and medication history. The important thing is, AI also has the potential to support a number of huge areas like drug discovery and clinical trials. But, some of the most critical concerns around AI and use of healthcare are around data privacy and security. That's because of the sensitivity of healthcare data, as the article points out. And you have to balance the challenge of accessibility of data, which you're just talking about getting it to be real time, and other privacy requirements like HIPAA, GDPR, or the EU AI Act. So it's important to build trust and transparency through the processes. So, by rigorous testing and demonstration of tangible benefits, particularly with underserved communities. So I think, all of those points are well taken. I think it gets to a point of talking about, helping people understand the models, helping people understand what's in them and being comfortable with them and building that trust. Your thoughts, Torrin?
Yeah, I actually really enjoyed this article. I thought it did a really good job kind of summarizing in relatively easy to understand English kind of some of the benefits of AIs while also, weighing that against some of the risk, right? We often talk about AI at length, but for those that aren't as, that don't live healthcare day in and day out like we do, a lot of people I would imagine are wondering, well, what does that really mean? Like, what are some tangible applications of how this could help me? And I thought this article did a really good job outlining those and kind of weighing the pros and cons. I think, we talked about this quite a bit already, but I see healthcare still being incredibly early in kind of their AI adoption curve. And as we all talked about, this AI kind of power or benefits associated with leveraging AI is really not going to be able to be unleashed until we figure out kind of this healthcare data problem. And it goes back to having that healthcare data strategy that Joe was talking about. I'm personally super optimistic about leveraging AI in a secure, compliant, and for way in healthcare, but that's only going to be possible once we figure out how to actually take advantage of the troves of healthcare data that we're sitting on and get it into systems like Snowflake. So I think a lot of this makes sense, but I also think it's important to acknowledge that we're still early. And I think figuring out how to get data from point A to point B within healthcare is a barrier that needs to be overcome first before we can really start taking advantage of some of these AI applications.
Yeah, no, I totally agree. And I think, to emphasize a couple of your points is the, getting that data in the right form and the right quality, I think is key to being able to use that. And I think people are, I don't know, maybe underestimating it is the right word. And, that's important. And I think the other thing is, there will be places, not frontline clinically that you can, make great use of AI in terms of making the patient experience easier in terms of scheduling and check-in and filling out forms. And, even I think Joe gave the example of going around the hospital, finding where a relative is with maps, which some, places are doing now. So, I think that's absolutely the case.
Yeah. Yeah. And I like that segmentation too of, the clinical pieces will take longer to develop, but I do think on the administrative side, there's some much lower hanging fruit that we could take advantage of sooner.
Yeah, my thought is on that I think that's one way to kind of bring the clinical side along is if you can show them, how some of these administrative things can save them time, make their lives easier, they'll be more likely to buy into some of these other uses, and they'll also gain some understanding of how the pieces work.
Yeah, I totally agree.
So with that, we're going to wrap it up. I'd like to thank Torrin for co-hosting with me. So as I said, I'm Jeff Englander, the founder and principal of Healthcare Strategy Bullpen. We help providers and payers adapt and deploy their healthcare tech to improve the lives of patients. We help health tech innovators be more effective in developing and deploying their technology within the healthcare delivery ecosystem. Basically doing that by focusing on 4 areas: operationalizing data to maximize its analytical value, as we're kind of referring to here, demonstrating the benefits of new applications enabled by digital health, applying digital health to high cost and chronic conditions, engaging and managing the practical, cultural, technological issues around social determinants of health. Please check out our latest blog, which is Lessons Learned on AI's Potential and Challenges in Transforming Healthcare, which is on our website. Feel free to connect with us on LinkedIn or Twitter. On Twitter, we are at healthcarepen.com. On LinkedIn and on the web, we are at healthcarebullpen.com. Subscribe to our blog, and please do subscribe to Diagnosing Healthtech. And with that, I will turn it over to Torrin to close us out.
Thanks, Jeff. Really enjoyed chatting with both you and Joe today. Our show is also sponsored by Redox, the leading source and destination agnostic healthcare integration platform. We provide providers, payers, and digital health organizations with the strongest data foundation for shifting to digital-first, value-based healthcare. As Jeff mentioned, be sure to subscribe to Diagnosing Healthtech on any podcast platform. You can also do that by scanning the QR code that you see here on the screen to get all relevant updates. Lastly, from all of us at Diagnosing Healthtech, thanks for watching and see you next time.
Thank you.